If you successfully treat a patient's depression, their anxiety might actually feel significantly worse before it gets better.
Oh, absolutely. It's a paradox we see in the clinic constantly.
Right. Why does that happen? Well, it's because you've essentially just given the engine of a broken down car a massive injection of fuel, but the steering is still, fundamentally misaligned.
That is such a perfect analogy for what we're dealing with.
You know the exact scenario. You're sitting in your clinic reviewing a chart, looking across from a patient who is just utterly exhausted.
And, I mean, it alters the entire recovery trajectory.
Exactly. And you're tuning into this analysis today because you are not new to the neuromodulation space. You already know the profound impact transcranial magnetic stimulation, or TMS,
You've
has.
seen the successes firsthand.
Yeah, but you also know that the textbook presentation of a patient with, pure isolated major depressive disorder is incredibly rare. The reality sitting in your chair is much messier.
It's messy and it's complicated. It's the patient with MDD who is also carrying this heavy, vibrating baseline of severe anxiety.
Which is why we are pulling from a massive stack of sources today. We're looking at recent clinical guidelines, resting state fMRI studies, mapping functional connectivity, and practical provider notes from the field.
Because when you have depression and anxiety symptoms presenting together, you're looking at a clinical picture that standard single-modality approaches frequently fail to fully resolve.
Right. Our mission today is to understand not just that TMS works, but how we maximize its clinical value for these complex overlapping presentations.
We really want to get into the mechanics of it.
Exactly. We want to look at how TMS, which, to be clear, is FDA cleared specifically for depression, dynamically alters the shared neural networks responsible for anxiety. And before we get into the biological mechanics, I want to mention that this discussion is brought to you by Sabres Medical at blossomtms.com.
It's an important discussion to have.
Okay, let's unpack this. We have to start with the baseline clinical conundrum. We're talking excessive worry, restlessness, physical tension, running parallel to a major depressive episode.
From a clinical standpoint, the presence of those anxiety symptoms just exponentially increases the overall symptom burden.
Oh, without a doubt.
It impairs the patient's cognitive flexibility, heightens their distress tolerance threshold, and frankly, complicates every single phase of recovery.
Well, and if you look at standard pharmacological treatments, SSRIs, for instance, they might successfully blunt the core depressive symptoms.
Right, the lethargy might lift, the anhedonia might fade.
Well, the anxiety-related symptoms often persist as these residual treatment-resistant features, or worse, they fluctuate independently of the mood symptoms.
Which leaves the patient feeling energized but entirely dysregulated.
Which is incredibly frustrating for you as the provider. You get their mood to a point where they can finally get out of bed, but they are immediately greeted by this persistent, free-floating dread.
It's a terrible spot for the patient to be in.
It really goes back to that car analogy. Treating the depression with standard medication while the anxiety persists is like finally fixing the engine of a car. You've got it running, it's moving forward, but you suddenly realize the steering pulls aggressively to the left.
Yeah, the engine failing and the steering pulling are distinct diagnostic labels, but they share the exact same underlying faulty wiring harness in the vehicle.
A shared wiring harness. I love that.
It's the perfect way to visualize the functional connectivity in the brain, honestly. We have to look beneath the DSM-5 labels.
Right, because the DSM separates them very neatly.
It does, but although depression and anxiety are categorized as distinct conditions, the fMRI resting state data from our sources shows they involve overlapping neural circuits.
So they're physically connected at a baseline level.
Exactly. We are seeing profound dysregulation in the exact same cortical and subcortical regions. Specifically, we see a distinct imbalance between the cognitive control networks, which are anchored by the prefrontal cortex, and the salience network.
And the salience network involves those deeper structures, right? Like the amygdala and the anterior cingulate cortex.
Spot on. They are absolutely sharing real estate.
Wow. So the patient has energy again, but that energy is being channeled right through a dysregulated stress response.
Yes, the energy is funneling into a system that just lacks top-down inhibitory control. In a healthy brain, the dorsolateral prefrontal cortex, or DLPFC, essentially acts as the brakes for the limbic system.
It regulates those raw, primitive emotional responses generated by the amygdala.
Right. But in patients presenting with both MDD and severe anxiety, the fMRI studies consistently show hypoactivity in the DLPFC paired with hyperreactivity in the amygdala.
So the brakes are worn out and the engine is revving.
Precisely.
That naturally leads to the big question for providers using neuromodulation. If these two conditions share that same wiring harness, how does a therapy like TMS, which is meant specifically for the engine of major depressive disorder, cascade down to affect the steering of those anxiety symptoms?
Well, let's talk about the biological mechanism, because we aren't just waving a magic wand over the scalp here.
Right, there's hard science happening.
What's fascinating here is the precise mechanism of action at the cellular level. When we utilize a standard high-frequency TMS protocol, say 10 hertz applied to the left DLPFC, we are using a rapidly alternating magnetic field.
And that magnetic field easily passes through the scalp and skull without resistance, right?
Exactly. And it induces a highly localized electrical current in the superficial cortical tissue.
Which forces the neurons in that specific area to depolarize.
It forces a rhythmic synchronization. We are inducing action potentials in a targeted network that has been chronically underactive.
But it goes beyond just temporarily waking up the cortex, doesn't it?
Oh, absolutely. Repeated stimulation over a course of several weeks triggers neuroplasticity. It stimulates the release of brain-derived neurotrophic factor, or BDNF, and promotes long-term potentiation at the synapses.
So we are literally strengthening the synaptic connections within the cognitive control network.
We are rebuilding the physical infrastructure.
And here's where I want to push back a little on how we talk about this in the field. We use words like targeted constantly. We talk about precise targeting of the left DLPFC.
We do say that a lot.
But hearing you describe this mechanism and looking at the network mapping studies in our source stack, it makes me wonder if we need to shift our mental model.
How so?
Well, we should maybe stop thinking of TMS as a sniper rifle that solely hits depression. It sounds much more like upgrading the local power grid.
Oh, I see where you're going with this.
Yeah, like you target the main substation, the prefrontal cortex, and by rebuilding that infrastructure, the surrounding neighborhoods like the limbic system suddenly stop experiencing brownouts and voltage spikes. You get a massive halo effect.
The power grid upgrade is a highly accurate representation of network-level healing.
It makes more sense than just viewing them as totally isolated systems.
It really does. The clinical relevance of TMS in patients with complex, overlapping symptoms lies entirely in its ability to restore functional connectivity across those distinct networks.
So as that prefrontal substation comes back online and strengthens its connections through long-term potentiation, the patient experiences secondary benefits.
Exactly. The brain regains its ability to send those crucial top-down inhibitory signals to the amygdala.
I want to make sure we are setting the clinical guidelines straight for the listener, though, because we don't want to blur the lines of what the hardware is actually cleared to do.
A vital clarification for sure. TMS treatment, in this context, is directed at major depressive disorder. It is FDA cleared for depression.
It is not targeted at anxiety as a standalone condition.
Correct. Any reduction in anxiety-related features the rumination, the heightened autonomic arousal, the persistent stress responses, those are downstream secondary benefits.
They are the direct result of the overall network stabilization initiated to treat the depressive illness.
Right. It's that halo effect you mentioned.
Okay, so we have this powerful network-level healing happening. The power grid is getting upgraded, and the halo effect is sending inhibitory control down to the limbic system.
Yes.
But if I'm tracking the biology here, and we are relying on downstream neuroplasticity and long-term potentiation to rebuild that grid,
Yeah.
I mean, that means there is a serious lag.
There is absolutely a lag.
So what does the timeline actually look like for the patient sitting in your chair? Because a patient paralyzed by free-floating anxiety is not exactly primed to just sit back and be patient.
And that is why setting expectations is arguably the most critical component of clinical management in these complex cases.
I can imagine.
The structural changes at the synapse, the neuroplasticity we just discussed, take time. It unfolds over weeks.
Because you're physically growing and strengthening connections.
Exactly. Because of the network dynamics, the timeline for symptom improvement often fractures between the two domains. Clinical observations show that patients frequently notice early improvements in their depressive symptoms.
Okay, so the lethargy lifts. They might feel a brief sense of mental clarity or increased energy by week 2 or 3.
But the anxiety trails behind.
Wow. So the anxiety stabilizes much more gradually.
Yes, it takes significantly longer for those deeper neural networks in the limbic system to structurally adapt to the new regulatory signals coming from the prefrontal cortex.
That makes biological sense.
The synapses in the top-down inhibitory pathways have to physically strengthen before the patient feels a reduction in their baseline tension.
Which creates a fascinating but, potentially dangerous window in the clinic. You have a gap of time where the patient has the energy of their depression lifting, but they are still saddled with the hyperreactivity of their anxiety.
It's a very vulnerable period for them.
And if we look at the practical provider notes from our sources, we have to consider the physical reality of the treatment itself.
Right, the sensory experience of sitting in the chair.
Because TMS is generally well tolerated and it doesn't have the systemic side effects of medication, which is great, but patients with prominent anxiety are inherently hypervigilant. They are scanning their environment for threats.
If we connect this to the bigger picture of the patient experience, the introduction of a novel sensory input can be highly triggering.
Because you are introducing the loud, repetitive clicking sound of the machine.
And you have the physical tapping sensation of the magnetic coil against the scalp.
Right. If a patient is already prone to excessive worry and physical tension, this unfamiliar sensory experience can temporarily elevate their autonomic distress.
Absolutely. This is where the clinical management truly gets put to the test.
If you have an anxious patient who is hyperreactive to the physical sensation of the coil, and you know as the provider that their primary relief from that anxiety is going to trail weeks behind their mood relief, how do you navigate that?
It's challenging.
Because the risk here is obvious, right? The patient gets uncomfortable in week 1, they don't see immediate anxiety relief by week 2, and they abandon the entire comprehensive treatment plan long before the brain has had time to undergo that crucial neuroplasticity.
That's the primary danger.
Mm-hmm.
And avoiding it requires an aggressive, proactive educational foundation from the very first consultation.
So you have to get ahead of it.
You cannot wait for the patient to express discomfort. You have to preempt it. Providers must normalize the sensory sensitivity immediately.
You have to explain the biological timeline that the mood will likely lift before the physical tension dissipates, precisely because of how the brain rebuilds its networks.
You essentially have to teach them the neuroscience of their own delayed gratification.
I love that phrasing, teaching them the neuroscience of delayed gratification.
You really do. And when patients have that appropriate clinical support and they truly understand the biological mechanism behind the timeline, their adherence rates remain remarkably high.
Because they know what to expect. They adapt to the sensory input.
Exactly. And remember, TMS is most effective when it is integrated into a comprehensive care plan.
Right. It's not happening in a vacuum.
The cognitive behavioral strategies, the psychotherapy, the careful medication management, those elements are what support the patient's short-term distress tolerance, while the TMS does the heavy biological lifting for long-term emotional regulation.
It really highlights that navigating this specific clinical picture requires incredible bedside manner. You have to be an anchor for the patient, holding their hand through the sensory adjustment and managing the gap between mood relief and anxiety stabilization.
You really have to project confidence.
But here's the hard truth for any provider. To have the confidence to be that anchor, you have to have absolute faith in the hardware delivering the therapy.
Oh, without a doubt. Spatial precision is the variable that makes or breaks the downstream network effect.
Exactly. Knowing that the prefrontal cortex needs sustained, rhythmic synchronization doesn't help you at all if your magnetic pulse isn't consistently hitting the target.
And patients aren't mannequins.
Right. If you have an anxious, hypervigilant patient in the chair, they aren't sitting like a statue. They flinch at the sound. They tense their neck muscles. They shift their posture.
They are a moving target.
And we have to remember the physics of a magnetic field.
Right, the inverse square law.
The strength of the magnetic field decays exponentially with distance. Even a millimeter shift in the position of the coil relative to the targeted cortical tissue results in a massive drop in the induced electrical current.
And if the current drops, you lose the depolarization, you lose the action potentials, and you completely fail to trigger the neuroplasticity required to rebuild those top-down inhibitory pathways.
Which means the halo effect never reaches the limbic system, and the anxiety persists.
Exactly.
This is why the specific technology you put in your clinic matters immensely. You can't be fighting your own machine or second-guessing your coil placement while you are trying to manage a highly sensitive patient.
This is exactly why advanced precision-engineered systems are critical for modern practices. The Blossom TMS therapy system, for instance, is designed specifically to support clinicians in delivering high-quality TMS treatment for FDA-cleared depression with unwavering consistency.
It has to account for the real-world variables.
It accounts for the physical realities of treating complex patients.
Because that precision is the linchpin. If you are trying to achieve reliable neuromodulation across a wide range of sensitive patient presentations, patients whose anatomy varies, whose sensory tolerance fluctuates, the device has to completely remove the technological guesswork.
It has to be dependable.
The Blossom system aligns with modern clinical environments because it allows the provider to focus entirely on the human being in the chair. You are using a highly precise, reliable tool to unlock those secondary anxiety benefits without worrying about the variables of the hardware.
Dependable stimulation delivery allows the clinical focus to remain where it belongs,
Uh-huh.
on individualized care,
Right, on the patient.
on monitoring subtle symptom shifts across the different domains, and on supporting the patient through the neuroplastic adaptation process.
That support is crucial.
The presence of severe anxiety symptoms does not preclude a patient from benefiting from TMS for depression. In fact, the resting state fMRI data clearly indicates that these complex patients can achieve profound functional recovery.
But the treatment execution must remain flawlessly consistent.
Flawlessly.
So what does this all mean for you, the provider listening today? Let's bring the core insights from our sources together.
It's a lot to synthesize.
It is. Treating MDD with co-occurring anxiety via TMS is a highly effective approach that works by engaging and upgrading shared neural networks. You are targeting the DLPFC to treat the depression, and by forcing long-term potentiation in that area, you are rebuilding the power grid that sends inhibitory control down to the limbic structures.
That's the biological foundation.
But that biological mechanism dictates your clinical timeline. It requires managing the gap where mood improves before anxiety stabilizes. It requires proactively managing early physical sensitivities to the coil, and fundamentally, it requires absolute precision.
It really does.
Delivering consistent network-level healing means relying on technology like the Blossom TMS system to ensure that your prefrontal modulation is accurate every single time.
It represents a truly paradigm-shifting treatment option within modern mental health care.
It really does change the game.
By influencing these shared neural networks, TMS, for FDA-cleared depression, can facilitate deeply meaningful improvements in a patient's overall emotional regulation, especially when it anchors a broader comprehensive care approach.
We want to remind you that this discussion was brought to you by Sabres Medical at blossomtms.com. If you want to ensure your clinic is equipped with the precision required for these complex, overlapping patient presentations, you can contact sales at sabresmedical.com or call +1.833.328.9867 to learn more about integrating the Blossom TMS therapy system into your practice.
This raises an important question based on everything we've seen in the functional connectivity data today. If targeted neuromodulation successfully treats the shared networks of stress and emotional regulation, rather than just checking off a specific, isolated symptom list, will the future of advanced mental health treatment force us as providers to finally abandon rigid, distinct diagnostic labels and instead focus entirely on network-specific healing?